Thanks very much.
Thank you so much. You get my stuff out of your way.
Thank you all very much for that introduction. Thanks, Dr. Nordal and Hook'em Horns. It's a real pleasure to be with you all here this afternoon because, as you heard from Dr. Nordal and as you know from your practice, you all are right at the center of the future of healthcare reform. And to pick up on the analogy that you heard a few minutes ago, this is sort of the start of the 2014 reforms for the coverage expansions under the ACA and the changes in payment that are going along with it. I know it probably doesn't feel like you're at the starting line for healthcare reform after everything that has happened involving psychology practice in past years, but it is a marathon. I completely agree with that, and I also agree with Dr. De Leon that for psychologists and really for all of the clinicians that have a potential to make a big difference in where healthcare and healthcare reform go from here, you are going to be valued to the extent that you can bring value to the big challenges facing our country, and those challenges in many ways are about getting to better care at a lower cost. Now, I'm going to talk today about several major topics on healthcare reform. I'm going to start with the fundamentals. So that's not the law, it's the things that are driving the law. These political decisions and reforms don't come out of nowhere. There are some underlying things that I think are very important in considering where healthcare policy reform is going to go from here. And I'll talk a little bit about the politics, but I want to spend most of the time on the need and the opportunities for clinician leadership in real reform of our healthcare and mental health services systems in this country. There are so many things going on around the country today, many of which you all are involved in leading, that show that we can do better. We can have much more value for patients. We can get to much better health, including much better mental health, but it is going to be challenging to get there. And I want to focus the last part of my talk on some of the key policy steps that I think can make a big difference. Many of these you're already involved in, and on top of that, some more challenges around payment reforms, around thinking about how the insurance exchanges are going to be implemented that I think fit in with the work that you all are doing in states all over the country. The action is going to be at the state level, so this conference and your work is both timely and important. And I'll try to leave some time for our discussion at the end with Dan Abramson about some of the further steps that can be taken to help make all this happen. So that's a little bit of an overview for today. I am an economist, as you heard from my introduction, so I have to start with a couple of slides on the big picture from the economic standpoint. And this should not be news to you, but the challenges that we're facing due to fiscal pressures from rising healthcare costs, including costs of mental health services, are very real. This chart divides our nation's federal spending into three categories going back to 1970 and projected forward through the retirement of the baby boom over the next 25 years or so. The red is the healthcare program, so that's Medicare, Medicaid, the new subsidies for insurance coverage under the exchanges, and the like. The blue is Social Security, and the green is everything else that the federal government does. You can see around where we are right now, that big spike was the 2008 Great Recession. We're now on the downside slope of that. It used to be the fiscal cliff. Now with the sequestration, all that looks more like the fiscal slope. And that was a big part of the big deficits that we've had over the last few years that have come down a bit. But you can see from this chart that really the whole story on the spending side for the nation's long-term fiscal crises at the federal level is driven by the rising spending on healthcare programs. So they're going to go up by about, the federal level, about 4 percentage points of GDP over the next 20 to 25 years. Social Security is rising with the retirement of the baby boom, maybe 1% of GDP, and everything else that the federal government does, research, education support, low income, social services programs, national defense, all of that is projected to get squeezed down. You're seeing this in miniature form in sequestration right now, where entitlement spending is continuing to grow and everything else is starting to get squeezed. That's the federal level. I know you all work more at the state level. This is a summary of state budget outlooks from the past year, so what happened between 2012 and 2011 in state spending. First column, all the increase has been in Medicaid and related health care programs. Every other major category of state spending overall nationwide on average has either held steady at best for things like corrections or gone down for things like spending on education and infrastructure. So the federal level, the state level, the spending pressures related to health care are the big story. And I know it seems like it's challenging right now, but what these graphs show you, federal level, and I could project this forward for the next 5 years for the states too, is that the pressure is going to get a lot higher, not going away. Now, while these things are going on the spending side, keep in mind that Americans are going along with spending more on health care and mental health services, not because they think it's all a waste. There certainly are opportunities for improvement, but because of how much these services can do for them. I mean, it's great that we can spend more over time on iPods and iPhones and jet travel and 300 cable channels, but what people really enjoy is the time to use all of those things, or time with their family, or enjoying the sunsets, and being in a mental health state where they can appreciate and enjoy all that. So it's no accident that healthcare spending is going up and mental health spending is going up along with it, because there's more and more that these services can do to help Americans. And that's really the rock and the hard place for healthcare reform. How do you get the improvements in health that we have so much promise to deliver on in the years ahead? You know, I think we've done a lot in terms of medical progress and mental health services progress over the last 20 years. Think about what can be coming over the next 20. How can we achieve that while still meeting these really challenging, increasingly challenging economic and cost pressures? So with that, I want to turn to the politics a bit. And I just want to focus on two issues in the interest of time. One is the coming implementation of the Affordable Care Act, which is going to be a very big deal at the state level, and it's going to be different from state to state. And the other is possible major legislation affecting all of this at the federal level. So as a result of the election, as a result of the Supreme Court decision, the ACA is going to stay. The coverage expansions are going to be there. There won't be any delay in starting. But I think you can expect to see a lot of variation across states. And I know many of you are in states that have state-run exchanges. Dr. Nordal talked earlier about Massachusetts, Maryland, California, places like that have been working through legislation, through education and outreach, through lots of implementation planning for months to get their programs off the ground. There are a number of other states that are working with the federal government but relying on a federal infrastructure. In many states, about half, that are almost entirely relying on a federal fallback exchange and other steps from the federal government to support implementation. Over the next couple of months, the federal government will know a lot more about what kinds of plans exactly will be offered. You know, how much is it going to cost for different tiers, so-called metal levels of coverage, and how many of these plans will be available. It may vary by state. The insurance environments and the regulatory environments and the political environments are quite different. There will be a great need for education enrollment. If we have time to talk about it later, having lived through, while I was at Medicare, the implementation of Medicare Part D, I can tell you the single biggest and most important thing for getting a new voluntary federal program off the ground. You know, all these operational issues, essential health benefit regulation and so forth is very important, but outreach and education to the public is the big thing. For voluntary programs, even if they're free, even if they look like a very good deal for many people, there's still a lot of inertia to overcome because of confusion, because of lack of being informed about these programs, and because of the challenges that may not seem that hard to many of us, but the challenges in actually getting enrolled. I think the upshot of all of this is that there's going to be a lot of variation across states in how the ACA gets off the ground. Some states faster than others. If you look at every other voluntary federal program that's been implemented at the state level, including Medicaid, including S-CHIP, there are big variations in when states started to take it up. It's going to be true for the Medicaid expansions here as well. So again, keeping with that marathon analogy, I wouldn't be too surprised if the enrollment numbers right off the bat, especially in all the states that have been relying on the federal government and the federal fallback, were not all that big at the beginning. Now, will be coverage available, but I doubt you're going to see enrollment levels 10, 15 million people. It's probably going to be more of a gradual process than that. And so I think viewing the implementation of the ACA from the standpoint of a phase-in, something that's going to happen over a period of months to years, not going to all be up and running with everybody enrolled in January 1st is very important, and also is important for all of you in thinking about your further work with states. While the focus right now is on getting things up and running for open enrollment on October 1st and coverage starting on January 1st, 2014, remember that states have to make decisions this fall about what they're going to do in terms of their implementation of the law in 2015. So are they going to become partnership states where they'll have a bigger role in insurance regulation and administering and setting up and implementing the plans? Are they going to keep waiting and seeing what happens? Now's the time to be thinking ahead to those longer term issues as well. So it's going to be a marathon there too. Moving ahead, I want to talk about how these kinds of steps fit into those bigger economic pressures. And I know from talking to Dr. Nordal and others here that you, like many other health professionals, are feeling squeezed by these rising health care costs. And those numbers that I showed you before on Medicare spending, for example, and on Medicaid spending, built in already are a lot of steps to squeeze down the payment rates of providers, because this is kind of the traditional approach for bringing down spending, at least in the short term, when we don't have a better solution. Reduce the payment rates to providers, delay access to coverage to new types of care. And as you all mentioned, psychological services weren't covered in Medicare for 25 years. At least you were a little bit ahead of prescription drugs. That was 40 years. That's not the best way to deliver high-value care, but it does lead to some short-term budgetary savings. Limits our non-coverage for mental health services in Medicaid is another example of this that you all are very familiar with. And again, while these steps are very commonly used to try to address those short-term budgetary pressures, they don't really provide a pathway forward to delivering better care and delivering on that promise of even better mental health and healthcare services generally in the future, with a lot more potential to improve lives, to lengthen lives. And so a lot of the reforms that I think are coming to the fore now, and talk about, we'll go through the acronyms, the ACOs and all that kind of stuff, are really driven by a more fundamental factor, and that is the need to do better to align financing with what's needed in healthcare and mental health services delivery than can be done through relying on traditional fee-for-service payment systems. And this is where leadership from clinicians like you really comes in. The goal here is not about getting short-term savings. It's about value. It's about how we can find better ways to improve health without spending more money overall, given how much tighter resources are going to become. And for this reason, I think leadership from physicians, from other clinicians, from psychologists, is going to be absolutely crucial to the next round, to the further implementation of healthcare reform. And that's what I call real healthcare reform. It's not the policy changes, important as those are, whether payment rates are reduced further, whether we move to different kinds of financing and regulatory model. So those are really important for how care gets delivered, but real healthcare reform is changes in health services, changes in mental health services practice that lead to better results at a lower cost. This is very hard to do, but it's absolutely essential for finding a better alternative to simply squeezing down the rates and hoping for the best in our healthcare system. We've done a lot of work on these kinds of issues at Brookings. We have another report coming out soon within the next month, so just a little quick plug for that on bending the curve while improving value. And I want to talk about the main elements of that in the remainder of my time with you from the standpoint of clinician leadership and from the standpoint of work that you all can do at the state level, you and your colleagues can do at the federal level to help get to that better system for delivering services. This is very hard to do, and a lot of the debate in healthcare comes down to one side attacking the other for what they think are going to be approaches that won't actually improve care. And remember, although a lot of the healthcare reform debate is motivated by the need to save money, every time, if you look at our history over the last 30 years, and I showed that to you on the slide, when the American public has had to make a choice between spending, say, a lot less on health care versus running the risk of significantly or fundamentally leading to less access to care and less quality of care, they've consistently showed that they want to spend more on health care. In fact, the way that you win a health care debate in this country, if you're a Republican, you say, fill in the blank, name that policy, this reform is going to lead to the government interfering with the care that's best for you and your family from the clinicians that you work with. If you're a Democrat, the way to criticize the Republican proposals is just the opposite. Blank, fill in the blank, the name of the policy is going to result in health plans, private for-profit companies getting in the way of the care that you need. So the opportunity for leadership here is not going to come really from government. It's not going to come from private health insurers. The American public doesn't trust either of them, really. The people that they trust are you, they're clinicians. The psychologists, the nurses, the physicians, the others who are involved in their care. The challenge is, though, that historically there hasn't been a lot of the leadership really coming on policy from that community in terms of doing more in this fundamental reform that I'm talking about here, doing more to move away from fee-for-service and fighting over the rates and fighting over what exactly gets covered to laying out a vision and getting to better results for care. And I don't know if we can bring the slide back up that I was showing a second ago, but what's, I think, the right way for healthcare reform is really laying out that vision for what should healthcare look like. Not the payment rates, not those kinds of things, but what should healthcare look like in a way the public can support. They will believe you, they will not believe the government, they will not believe the private insurers. And then going a step beyond that, which is how do we get there from here? Now, we have a payment system, including for most psychological services today, that's still fee-for-service, meaning you provide more services, you get paid more. It's not tied to, necessarily, these innovative ways of delivering care that lead to better results at a lower cost. Getting there from here is very challenging, but again, I think it should increasingly be part of the policy reform efforts that you and other clinical leaders should be championing. And in implementing these kinds of reforms, it takes other sorts of skills. Very important to be good with your patient and know that the best and the latest clinical science for their care in their particular circumstances. Also, though, increasingly important to understand the financial issues, the regulatory environment, the management issues that come up in delivering these kinds of services effectively and as efficiently as possible. And so that's what I want to talk about during the rest of my time with you. In terms of opportunities, I would ask you about this, as you all know much better than I do, but it seems to me that there are an awful lot of opportunities to get to better health, better mental health for Americans at a lower cost than what we're doing and what we've been able to achieve now. Dr. Nordal talked about some of these programs around the country that are focusing on ways of coordinating mental health services, psychological services with other types of health care, including more efficient ways of doing screening. Depression, other mental health conditions are way underdiagnosed in the public, leading to significantly worse outcomes and in many cases higher health care costs. So screening, referral, coordination with physical health service providers, primary care providers are some good opportunities for improving health and lowering costs. Maybe in some cases there are more minor situations that can be handled by other health professionals besides fully trained clinical psychologists, maybe lower cost ways we can help target your services to the people who can get the most out of them. That too can increase value. Managing patients with both mental and physical illnesses. I can't tell you how many organizations I've worked with around the country that as they have moved forward on reforms in this direction of getting to better value for their patients, they more and more integrate mental health with physical health services because so many of the patients that end up spending a lot of money on the acute medical health care side in emergency rooms with preventable complications of their chronic and acute diseases have coexisting mental health conditions that complicate their ability to change their behavior, their ability to adhere to effective evidence-based medication therapy, and otherwise have problems that result in their ending up in the emergency room or in the hospital or with further complications of their chronic diseases. You've seen in many psychological practices around the country, in Oregon and elsewhere, health engagement teams that involve psychologists with other clinicians, not just physicians, but really a well-targeted clinical team, maybe including social workers, other allied health professionals to get the right set of services to each patient. These kinds of coordination approaches, if you think about them, are not very well supported in our traditional financing systems where you just get paid fee for service, maybe fee for a visit or something like that. And so finding better ways to support these efforts is really important for healthcare reform. Aside from all these kinds of steps along the lines of better coordination of psychological services with other types of medical services are perhaps some opportunities for improvements in practice. And again, you all would know much better than I would about these, but it seems like, if anything, psychological services are becoming more diverse. Yes, there is the traditional psychotherapy and individual office visits and things like that, but there are a lot of other types of services as well. Group services, more targeted, focused individual interventions, programs that rely on distance services, video services and the like, more targeted interventions other than just referring patients to the 911 emergency number if they're having an acute exacerbation on an evening or a weekend, finding ways to fill in and meet those needs. And using within psychology programs and mental health services programs teams of practitioners. Again, it may not take a PhD psychologist to do everything, every kind of thing that a patient needs, but maybe a collaborative team involving other types of health professionals, social services workers, people who maybe don't have quite the degree of training that many of you all do, but are able to provide very valuable services, could be part of these efforts as well. Again, not very well, doesn't fit very well into our traditional kinds of reimbursement systems. So that brings me to the kinds of reforms that I think can help get from there to here, to help overcome this lack of alignment between where psychological practice can go to get to more value, to get to making a difference in our healthcare system in terms of better outcomes at a lower cost, and where we are now. It's not supported very well by the policies we have in place, and I'll try to help identify some ways to overcome that in the next few minutes. This all starts with measurement, data and evidence. One of the most distinguishing features of our traditional payment system is that if you look at Medicare programs and Medicaid programs, they've got really good at measuring things like how many visits you have, when you go to the hospital, what services, what lab tests are performed, when you readmitted to the hospital, what diagnosis you have, because those are the basis of our traditional payment systems. And if you want to do more to support other ways of delivering care, you really have to align the payment systems, the benefit design, the regulations with that, and that takes measurement. If you can't measure it, it's awfully hard to support it. And this is a big challenge because if you think about it, a lot of things that you're having an impact on are people in terms of people's long-term mental health and well-being are very hard to measure on a short-term basis, on a basis that could be an alternative foundation for healthcare policies. But this is starting to happen, not just in mental health services, but throughout the healthcare system. Measurement is the foundation for many of these reforms that I'm about to talk about. These include things like measures of use of preventive services and other things that can be captured in health insurance claims. There may be some measures here that are related to mental health services. I don't think there are many. But where much of measurement is going is bringing in additional clinical data, maybe not full electronic medical records because those are costly. They take time and effort to adopt and integrate, but that shouldn't be a reason we can't make incremental progress towards better measurement. So in this area, most of the reforms on the medical, on the physical health side include measures like, for patients with diabetes, indicators of how well they're doing, what the patient's blood sugar control is, or for patients with high blood pressure, how well controlled is their blood pressure, for patients with coronary artery disease, how well controlled are their lipids. These are clinical measures that are now being incorporated into regulations, payment systems, financing reforms, and the like. This has started to happen with some measures of quality related to mental health services. If you can put the slide back up, I'll show you some more of these. Services related to depression, depression screening, and treatment are included in many of the ACO programs. And there's a potential for doing a lot more. What I call longitudinal outcome measures at the bottom is where the measurement innovation community would like to head. Measures that are more based on patient-reported outcomes. Things like functional status, things like changes in their risk factors for complications, things like potential mental health status measures as well. So with better measures, it's possible to support better reforms. And this is not measurement in a research sense. These are measures that are being used on a routine basis in all of the kinds of healthcare reform programs that rely on new approaches to financing, new alternatives to fee-for-service. So with better measures, it's possible to support different kinds of financing systems and get to that alignment between the kind of coordinated care, the kind of patient-focused, individualized care that could lead to better results for patients at a lower overall cost and help us get both a better way of addressing our nation's fiscal challenges and a better way of capitalizing on the biomedical knowledge, the mental health knowledge that we have today and that's coming along in terms of further innovation. And provider payment probably gets the most attention in this area. I've been doing a lot of work for now a number of years on accountable care and accountable care organizations. Had an op-ed in the Wall Street Journal just this past week talking about some of the innovations in this area. And again, there's a lot of acronyms and a lot of technical detail, but the basic concept is not that complicated here. It's about moving away from paying based on volume and intensity, and paying providers based on what we really want, better results at a lower cost. That is not easy to do because coming up with good measures of better results and costs is not always straightforward, especially in areas like mental health services. And that's why this is a gradual process, or at least the most effective strategies are implementing it through a step-by-step approach that identifies opportunities for clinical improvement and cost reduction that are measurable and then builds on them year after year, builds up the systems, builds up the interventions, again, with a focus on measurable results. First meeting I had about these shared savings programs when I was at CMS, when overseeing the Medicare program back in 2005, was with the heads of a number of physician group practice services. These were not hospital-based organizations. They were multi-specialty group practices that went through a laundry list of things that they were doing that they thought were helping get their patients better results and saving money at the same time. Things like using email to reach out to their Medicare beneficiaries who were healthy but were eligible for screening for cancer or flu vaccines and the like. Things like setting up teams to help manage their patients with chronic diseases like diabetes or heart failure. When there was a gap in a prescription being filled or a preventable admission to the hospital, or in some of the programs even a sign in their electronic record systems, which weren't paid for either, that a patient was likely to be admitted to the emergency room or the hospital, they could intervene in a targeted way with those patients. Also programs that help manage the patients who were admitted to the hospital with serious illnesses and were having, could have problems with their medications, with their transitions to post-acute care and outside the hospital that, if not handled well, would make them in that group of 1 in 5 Medicare beneficiaries who's readmitted to the hospital within 30 days of discharge. What all these programs had in common, and what the reason for that they were coming to see me, was that, number one, they could show that these programs worked. They had measures along the lines I was describing before that showed better results for their patients. And number two, they saved money, that overall resource use was down. But as every single one of those group practice CEOs told me, we're getting killed in doing this because Medicare doesn't pay for any of it, because fee-for-service systems don't pay for any of it. Medicaid programs have the same kind of conversations, or it's even worse, especially for things like mental health services. So what we did was set up a second payment track for these kinds of groups. It started out as a pilot program. It became the Medicare ACO initiative, where we had the following arrangement. So the group still got some of their traditional payments. This wasn't a radical change from the way they were getting paid, although we were aiming for that fundamental change over time. but they started reporting on a set of measures that we and they agreed were important for the health of their patients and which weren't being met all that well in our traditional healthcare system. Measures like hemoglobin A1C levels for patients with diabetes, a measure of as a measure of diabetes control. Measures like hospitalization rates for preventable complications for chronic diseases. Measures like patient experience with care and whether patients felt like they had well-coordinated services, so-called HCAHPS measures. And the deal was if the groups could show improvements in most of these dimensions of quality, and if Medicare saw a reduction in overall cost trends, if they just slowed down the overall rate of growth of costs, the physician groups, the provider groups, got to keep most of the savings. And what that did was provide a lot of resources that could be used to support the kinds of activities that are not reimbursed well or not reimbursed at all under traditional kinds of reimbursement systems. Now, these kinds of ACOs are still very much in the early stages. When we started this program in 2006, we had 10 sites around the country. At Brookings, in collaboration with Dartmouth, we now have an ACO learning network that includes a lot of the organizations that are implementing ACOs today. They are all over the country. They have found ways to work with corporate practice of medicine laws and so forth to form collaborations that start to take on this responsibility, this accountability for getting population-level measurable health results up and overall costs down at the same time. And what many of these organizations are doing, especially in the private sector, is moving on from just having this second track of payment based on shared savings. You know, you get your fee-for-service payments, and in addition, if you show overall improvements in measurable results and reductions in costs, you get an additional payment. They're taking more of their traditional payments from fee-for-service and putting them in a what people call risk-based payments, two-sided risk, partial capitation, because they have been able to invest over time, step by step, in initiatives to get to better results at a lower cost for their patients, build up data systems and infrastructure support, team-based approaches to care, ways of coordinating with specialists and the like that they hadn't done before because it just didn't pay. They just lost money on it. They couldn't continue doing it and sustain their practices. And they've kept learning. And so what a lot of people view this as, it's uncertainty because these are new ways of being paid, not used to it, and that's why I think the best way to approach them is not, all or nothing, move from a traditional fee-for-service payment system, boom, into something completely different, but in this kind of incremental approach where you can build up experience over time. Right now, as you all well know, in your practice, probably a lot of the things you do, wish I could do a survey, but I would guess a lot of the things that you do are reimbursed poorly or not at all, even though they make a big difference for your patients. Yes, you get paid for the office visits, maybe you get paid for some other things, but if you think about it, what individual patients might need are probably not very well captured in a fee schedule that's relevant to your practice. Under these approaches, you still have things that you're not going to get paid for. You still have financial risk, but organizations that have adopted these reforms have gotten more familiar with what kinds of uncertainty in this new world focused on patient outcomes at a lower cost, what kinds of uncertainty they're facing, and have gradually become comfortable with taking on more and more of it. So that's sort of the pathway for accountable care payment reforms. Many of these are being implemented now in the public sector, so in the traditional Medicare program, ACOs, both shared savings and these partial risk versions, the so-called Pioneer and group practice transition programs, now cover more than 12% of traditional Medicare fee-for-service beneficiaries and growing pretty rapidly. Many state Medicaid programs are implementing these kinds of reforms as well. Massachusetts just this week issued their request for proposals on community-based care organizations that are aiming for kind of a new version of safety net care and care for lower-income Medicaid-eligible beneficiaries in Massachusetts, involving public hospitals, involving community-based mental health services, and other collaborations of providers. I think some of you may be here from Oregon, where the state is implementing its so-called CCO, community care organizations, which again are a community-based approach focused on better outcomes at a lower cost, focus on this transition from fee-for-service payment to paying based on measurable improvements in results, measurable improvements in value. So these programs are coming along. A question that Dan asked me beforehand was, how fast do you think this is all going to happen? Well, it depends a lot on the experience of the next couple of years, and again, depends more than anything else on how the clinician community, including how the mental health services and psychology community approach these issues. If you can find effective ways forward, then I think we're going to see it happen faster. What I can tell you for sure is, talking about, going back to those fundamentals that I mentioned at the beginning, we're not staying with fee-for-service as a predominant model of payment in this country. There certainly will be a diversity of practices out there in both psychology and other areas of health services where fee-for-service will continue. But if you look at the fundamentals in both economics and biomedical technology, we're heading towards more and more personalized, individualized services for patients that require, that as a result of more knowledge about what works best for them and what combinations of treatments and combinations of services work best for them, are getting more and more individualized. Fee-for-service just fundamentally doesn't do well as things get more complex and need to get more individualized. What does do well is reliance on health professionals like you who know, who are in the best position to know what combination of services is best for individual patients. And that means accountability moving more towards your control and your responsibility for helping those patients get the best results at the lowest cost. So there are other examples of kind of moving in the same direction as ACOs, bundled payments. So these are payments not for the whole set of services for a patient, but maybe a component of it. So say for heart failure, coronary artery disease, for patients who are undergoing bypass surgery. Here too, focus on having an overall payment goal, so getting costs down, and an overall quality improvement goal, so measures of better health outcomes. So for example, in some of these bypass surgery episodes, an outcome measure might be how quickly a patient is out of the hospital, whether or not they have certain major complications, how quickly they're back at work, and obviously getting the overall cost of doing the whole elective surgical procedure down. Many of these bundled payment approaches are including mental health services providers in their reform efforts because, as you know, for patients who are undergoing these major procedures, depression, dealing with changes in lifestyle, dealing with changes in personal circumstance can be very challenging, and it can make a big difference to have targeted services that work well for the individuals. In fact, if you think about a lot of the reforms that are out there, a lot of people are saying, well, let's try out all these different payment reforms, throw a bunch of stuff against the wall, see what sticks, spaghetti-like. That's not the way I see it. See, again, the fundamental trend here in a whole range of reforms, whether it's medical homes for primary care or bundled payments for specialty services or for particular chronic illnesses or accountable care payments for whole populations, all of it has in common that they are using measures based on what we care about, results of care, evidence-based treatments and the like, lower overall cost, to support more personalized services, more prevention-oriented services for patients. And it is hard to do this right. This is happening gradually. It's happening in different ways around the country. We haven't worked out the best techniques, but the fundamental trend is there, and I think it's going to accelerate. And that brings me to payment for clinician services in particular. This is a chart for Medicare physician payments, and I know that's not exactly your biggest problem, but to the extent that you're billing under Medicare Part B as well, you've seen the same thing as physicians and clinicians generally in Medicare have seen, which is your payments have not come anywhere near keeping up with inflation, let alone with your costs, under the so-called SGR. This is kind of the traditional approach to trying to control costs in healthcare systems, right? Squeeze down the provider payments. And every year there's a fix at the last minute that doesn't fully fix the problem. And every year there's therefore more frustration on healthcare professionals because they're getting paid less and expected to do more. And in many cases they're not getting paid at all for the services that are making the most difference for their patients. I think this is about to change. This could be part of that reform in healthcare and entitlements that could be coming later this year as part of a so-called grand bargain on dealing with our long-term fiscal outlook, maybe raising taxes and including some entitlement reforms at the same time. What is very clear, though, is that the current system is not going to be sustainable. Current fee-for-service rates are inadequate or increasingly non-existent for some types of services that matter to patients. And the challenge has been, though, that for clinicians who are trying to lead efforts of reform, a lot of time the focus is on, and I understand it should be, on increasing payment rates in their specialty. So primary care physicians are advocating for more payments for medical homes, specialists are advocating for more payments that reflect their specialty services, and so on down the line, including psychological services, I would think as well. Where I think there's a big opportunity for supporting reform is in the fact that all of these services together, all these clinician services together, amount to only a tiny part of the cost in any healthcare system, whether it's Medicare, Medicaid, or otherwise. For example, in Medicare, professional services billing is only about 15, 16%, maybe 17% now of all of Medicare costs. The vast majority of costs are the things that clinician decisions influence. The use of drugs, the use of hospital services, the use of post-acute care services, the occurrence of costly complications and the like. And the problem of having payment reforms that focus just within your silo is that you're not recognizing the increasingly important connections. You know, that's what we've been talking about for most of the past hour, the increasingly important connections between what you do in your practice, in your time and involvement with patients, and the overall impacts on the healthcare system. And so I think there is growing support, bipartisan support in this case, for reforms that do recognize that linkage. So how would this work? Well, just as I was talking about in the case for ACOs generally, you could think about applying the same thing. And think about this, and this is kind of a challenge for you about whether you think it's relevant for your own practices. Think about some of the things that you're paid for on a fee-for-service basis that are probably least best fit to the individual needs of your patients, and whether some of those payments could move in a different direction. So following the example of primary care medical homes, same thing is true for many specialists and in innovative private plans and in ACOs. They're moving away from a pure fee-for-service basis of payment to having some part of payments tied to the person rather than how many times you see them and how intensively you treat them individually. In particular, you can think of case management fees. So this is sort of like a medical home payment, a per-person payment to a primary care physician for coordinating care and for implementing electronic records that allow better patient tracking and allow better monitoring for whether patients are getting the best evidence-based care, in conjunction with some accountability for not just whether or not they billed for the visit, but whether or not that patient has better results, whether their chronic diseases are having better outcomes, whether the overall costs are lower. Can the same thing happen in payments for psychological services for those of you who are in especially fee-for-service systems now? Similarly, there are a lot of opportunities for gains from care coordination, and just as ACOs include payments that involve sharing of the gains between, say, primary care physicians and specialists when they're able to refer more efficiently or avoid unnecessary costs. The same thing could support mental health services becoming more coordinated and more integrated with other types of medical services in ways that lead to lower overall costs and better results for patients as well. In other words, instead of having, as this chart's a little bit mislabeled, but just look at the left, your left to begin with, overall healthcare costs are the vertical size of these boxes. So again, most of it is not clinician services. The clinician fees are only a tiny part of the cost. If you can move part of your payments into payments that are tied to getting better results for patients within mental health services and better results for patients in terms of the coordination of mental health services with other healthcare services through the kinds of measures that I was talking about before, that's a way of capturing some of the savings that you can get, bringing down the overall healthcare costs and turning them into more revenues for clinical services, because that is, after all, what's most important in driving all of these healthcare decisions and potentially all of the healthcare costs in our system. Now, I've talked a lot about payment reforms and provider payment up until now. I want to switch gears and talk for the next few minutes about the beneficiary side of this, because that's very important as well. And I'm going to go back and tell another story from when I started off at CMS. The reason that, one of the main reasons I went to CMS in 2004 was as after the Medicare Modernization Act had been passed, which, as you know, created the drug benefit in Medicare, 40 years after the Medicare program was created. And there's a big question about whether and how that benefit could be implemented. For those of you who had patients who were trying to get started on Part D at the beginning of 2006 when the rollout occurred, you have my sympathy. I was out around the country in 2005 and heading into that open enrollment period, spending a lot of time with groups that were trying to help people find out about the benefit and make decisions about enrollment. And I can't tell you how many seniors I talked to who were really angry because they want to know, why was this so confusing? Why do I have to choose among 30, 40, 50 different plans? Why can't you just design a damn drug benefit for me and give it to me? Why do I have to get involved in all of this? Well, what happened as a result of this, the way that we set up the program, was some really interesting things in the way that the Medicare benefit has worked out. The law included a standard traditional insurance design for the Medicare benefit. In the first year, actually, one of the reasons we had so many plans was that all the competing health plans had to offer this standard kind of benefit. It had a deductible, it had a 25% coinsurance, it had catastrophic coverage on the back end for people who had very high drug costs, it had that famous donut hole in the middle, because back then we thought the drug benefit was going to cost a lot more than it ended up costing. Do you know how many people enrolled in that kind of plan? You know how many enrolled in it today? Almost none. The vast majority of people chose some non-traditional, at least at that time, benefit designs in Medicare, which had a tiered structure. And in this structure, and you're all familiar with these now, the generic drugs, the low-cost, really cost-effective drugs are basically free. They may cost like $1. The preferred brand name drugs are where there are a number of drugs in the same class, but they work pretty similarly for most patients, might cost $30 or so. And most other drugs would be covered, but they'd be on a higher tier. Now, we did have some additional protections in place for drugs for serious mental illnesses. We required all the plans to keep all of them on their formulary. And we took some other steps, too, that I'll talk about in a minute. I think were even more important, frankly, for that in trying to promote access to needed drug therapy for patients who have expensive, costly mental health pharmaceutical needs. But the main point that I'm trying to make here is that when you have a benefit structure like that, it's a very different experience for patients. So under a traditional benefit design, if there's a brand name drug and a generic drug for your health problem, and you switch from the brand name drug to the generic drug, you save maybe 20% or so of $80 or $90, between going from a brand name beta blocker to the generic version. So that's maybe $20 in your pocket. Under a tiered benefit design, you get almost all that savings. And what happened in the beginning of 2006 was that people saw these tiered benefit designs had lower premiums, and using our tools online and hearing from their friends, seemed to think that they would be able to cover most of the drugs generally that they needed, perhaps at a lower total out-of-pocket cost. They signed up for those plans, and then once they were in them, they switched their drugs. They switched from brands to generics at a huge rate. We're expecting a lot of complaints about this, by the way, and we did get a ton of complaints when the program got started, all about, why can't you just give me one plan to choose from? Why do I have to choose among all of these? Where's my data in the system? I signed up for this plan, and they don't have a record of me yet. We had lots of those kinds of complaints when we were getting started. Where we were expecting many more but didn't get many was in complaints of people who had these financial opportunities to save money when they switched from a brand to a generic or from a non-preferred to a preferred brand name drug. Instead, what we saw was huge and much higher rates than our actuaries had projected of people switching which kinds of drugs they got. So the use of generics in the Medicare program has gone from about 50% in 2006 when this program began to about 80% today. Think about how much money that saved. People have talked about the slowdown in Medicare spending over the last couple of years and how much the projected Medicare spending has come down. By the way, those improvements, those are included in that figure I showed you before, so don't get too optimistic about this. But half of that improvement in the past year was due to the cost of Part D being much lower than expected. The other half has been fewer hospitalizations, and the Part B stuff is still going up. But it's due to a lot more use of generics and a lot more use of preferred brands. And there has been a real change, and I think you all may have seen it, in biomedical innovation in the drug industry, where the push is now away from Me Too drugs and towards drugs that actually meet unmet medical needs. And we can come back to this question of, are they meeting those unmet medical needs at a cost that's too high? But at least there's not nearly as much spending as there used to be on kind of the Me Too therapies, and that has had, again, it's been reflected in this big impact on overall healthcare cost growth. That kind of approach has not yet come to the rest. This is a chart just showing projections. Originally, when we started Part D in 2006, what the actuary said the costs were going to be and what's actually happened. This year for 2013, premiums and average cost per person actually went down because of some of the kinds of trends that I was talking about before. And there are other factors too, but this is a big part of it. So the reason I emphasize this is because we haven't seen this kind of benefit design come, at least much, on a very value-based basis yet to the rest of healthcare, but I think it's coming. You know, think about how tiered benefit design is applied today for other services. You all probably have some experience with PPO plans and things like that, where if you're not a provider in the network, your services are either not reimbursed at all or reimbursed at a very low rate. What a lot of the ACOs and a lot of these payment reform organizations are doing with their health plans is setting up a more value-focused benefit design or value-based insurance design, where if you're a beneficiary and you choose an ACO or you choose a specialty provider for your chronic disease that has demonstrably better outcomes and lower overall costs, you get a lot more of the savings. This is very different than traditional insurance, where if you're hospitalized once, you're going to be above, I don't care if it's a high deductible health plan or whatever, you're going to be way above your out-of-pocket limit. Under these plans, if you go to a bypass surgeon who is clearly more efficient, if you go to get your chronic disease care from an organization that can show better results at a much lower cost, you can save potentially thousands of dollars, even if you've got a very serious chronic disease. Now, we have not figured out how to do this in a way that is nearly as convincing for the public as, say, that distinction I made between brand name and generic drugs is. You know, basically, seniors have shown us they completely believe that a brand and a generic drug is exactly the same. And for most classes of drugs, I'm not talking about mental health drugs for the most part now, but for most classes of drugs like cholesterol-lowering drugs, non-sedating antihistamines, oral hypoglycemic agents, things like that account for a huge part of outpatient drug costs today, they have similarly shown that they think brand name drugs that have similar mechanisms of action are basically the same. They're willing to switch. That hasn't happened yet for most of the rest of healthcare, but you can imagine as we get better measures, more compelling measures of what makes a difference, it will. In fact, in a lot of the ACOs that are forming now, many of the specialist organizations that are figuring out how to work with them are focusing much more than they used to on things like the complication rates from their procedures or the overall costs of services, specialty services they provide, or ways that they can coordinate care more effectively with the primary care physicians in these ACOs so that they can get to, again, demonstrably better outcomes, better measured outcomes at a significantly lower price, and then that's being passed on to the beneficiaries. So this is just starting to happen now, but I think you're going to see a lot more of it. And a good question for mental health services providers is, can this work, you know, to the extent that, again, you can show that you can get better results at a lower cost? Can you build that into benefit designs as well as these payment reforms to help lower overall spending growth and provide more access to highly valuable mental health services? And so it does bring me to a sort of a final issue that's very important in all of these kinds of reforms. As I mentioned, with the implementation of Part D, patient choice was very important. And it was very important to us in implementing the program that the insurers that people chose were ones that were going to do a good job, not just with the healthy people who had low costs, but with people who had the most serious chronic illnesses. In fact, I can tell you stories about how some of our early markers, our early indicators for whether or not Part D was actually working for access involved very close monitoring around sort of October, November to December 2005 into 2006 of how patients on Medicaid with serious mental illnesses were doing. As you figure that if there's an access problem, that's probably one of the conditions out of all of healthcare where even failing to have access to the medications that work best for you for just a few days could potentially lead to serious medical consequences, emergency room visits, and worse. That's something we watched very closely, and I actually saw a decline in those admissions for Medicaid patients with the implementation of Part D. But I think a big reason for that was not just that we required all the plans to cover all mental health drugs on their formularies, but because we took a lot of other steps to promote plans that attracted and could retain, because they provided good care and good access to medications, for the patients who had the most serious chronic illnesses. This is what I guess you might call it sort of the carrot side of, there's a big emphasis on, and has been appropriately a big emphasis on, essential health benefits and formulary requirements under the ACA as well. Something I think has not gotten as much attention under the ACA, at least publicly. Hopefully CMS is thinking about it, and hopefully the states are thinking about it, and hopefully you'll make sure the states are thinking about it, is these issues of risk adjustment and other support for plans that attract and keep people who have high expected costs because they have chronic diseases. We put a huge amount of effort into developing risk adjusters, including risk adjuster that had factors in it for various mental health conditions, as adjusters to the amount of money that plans got paid. And if you think about what may end up being a big challenge for the ACA, as I was talking about earlier, is you're probably not going to have a huge amount of enrollment right off the bat. We had big enrollment in Medicare Part D in the first year. It was below projections, but it was still good enough to get to stable prescription drug coverage market, something a lot of people thought wouldn't happen. We had that for a couple of reasons. One was the big education and outreach campaign. As I talked about, it's extremely important and needs to get going now for ACA as well. A second was the subsidies that people receive. So this was subsidized coverage, and that's true for lower income Americans under the new ACA subsidies as well. But a third was that we took a huge number of steps to make clear to plans that if they got into this market and guessed a bit wrong in the first year or two and ended up attracting people who were very costly users of drugs, they would have some protections against that. It's the same kind of uncertainty that I was talking about before that many providers are facing today when they're thinking about going into an ACO. And risk adjustment helps there as well, and reinsurance and things like that, where you basically tell the plans or tell the healthcare organizations that, look, if you are delivering better care, and because of that reason, people with serious chronic diseases want to come to you, we're going to pay you more. We're going to provide reinsurance. We're going to provide other steps to help make sure that your program is sustainable. If you really want to provide a strong incentive for health plans in the ACA to offer better coverage for mental health services generally, to offer better drug coverage for pharmaceuticals that are needed by people with mental illnesses, one of the best tools for doing that is strong risk adjusters and strong related steps to help provide direct financial support for the plans that do well at that. Now, I wanted to wrap up just by talking for a couple of minutes about what I see as some of the barriers for you all, and maybe we can have some more discussion of this to follow. I know of considerable concern has been laws that get in the way in some states of clinicians, mental health practitioners, psychologists working with other health professionals in a what might be called a corporate setting. As I showed you before, I think it is important to try to identify ways to change those laws that are just not keeping up with the times in terms of medical practice. But as I showed you before, at least in the ACO realm, for many different kinds of medical practices, there have been a number of ways to get around that, including in places like California and other states that have historically had significant corporate medicine barriers. One of those is through integrated systems like Kaiser and Geisinger and the like, but I know most people or many people don't want to practice, and it wouldn't be most efficient for them to practice in that kind of setting. One of the interesting things that we've seen about the ACO development in the last couple of years is that less than half today are actually organizations that are led by hospitals and are very institution-based. The majority of ACOs that have formed recently, and an even stronger majority of those that are forming in the private sector with private insurers, are ones that are contractual relationships among different clinician groups. So they might start, some of them just have primary care physician networks in them. Walgreens just announced back in January forming some ACOs that consist of primary care physician groups plus some pharmacies, plus Walmart's pharmacies, which they view as an alternative place for delivering acute care services and for managing patients with chronic diseases, helping keep them on their medications, checking their basic lab results and things like that. Doing that in the pharmacy instead of in a physician office after hours. It's more convenient for the patient. It's probably lower cost as well. Still trying to figure out whether and how that's going to work, but another model. There are other models of ACOs that involve primary care physicians with different kinds of specialists, other types of health professionals through contractual relationships. So they're not in a corporate, they're not in a, an entity like a hospital. They're just contractual relationships among the different clinicians. So Optimus in New Jersey has developed models that are now being used by a number of other private health plans as well that basically keep the different physician groups in their own groups. They include a lot of small physician practices in various parts of rural New Jersey, but they have some infrastructure behind them in terms of data systems to help these small groups of physicians track their patients to other specialists who are working as part of the ACO, other providers that are working as part of the ACO, and to track the overall financial performance of the organization, the overall quality performance of the organization, and then divvy up those funds. So it's kind of turning all that uncertainty around how do you deal with accountability for results at a patient level and costs at a patient level into something that's actually manageable without going into a fully integrated corporate practice setting. If you put the slide back up, go on to the next obstacle there, and that's obviously inadequate or no payment in an era when resources are getting tighter and tighter. I know it's tough today. It's going to get tougher in terms of the fee-for-service outlook. Now, there have been some law, the mental health parity law was passed in 2008, now being implemented in regulations that will probably provide some help in improving reimbursement for mental health services. I wouldn't count on a ton of help. The other things that I think could make a bigger difference are, first of all, breaking down the silos. So a lot of states and their Medicaid programs have done carve-outs of mental health services. The problem with that is that all the things that mental health providers can do that lower overall costs and improve outcomes on the rest of the healthcare spending, the rest of healthcare delivery, don't get counted in that kind of arrangement. So that's a problem for Part D plans as well. What Part D plans are now experimenting with some ACOs is a shared savings approach. So even if you can't fully break down the silo, at least start tracking overall outcomes and tie payment. States can do this, tie the payments in the mental health services piece, the impact of mental health services on the rest of costs. Better measures. So today, some, I'd say at best modest mental health service-related measures are in use in some of these accountable care and other payment reform initiatives. There's some related to depression. There's a lot of interest in adding a measure related to post-hospitalization care for patients who are admitted with a mental health condition, an inpatient admission with a mental health condition. I think that one's got a lot of opportunity for broad adoption in both Medicare and Medicaid. But if you think about it, there are a lot of, you're hardly touching the surface of the kinds of things that mental health service providers can do to influence outcomes that matter for patients. We don't do a very good job of capturing it with measures. If they're not measured very well, they're not going to be as much of a priority in this movement towards a feasible path for identifiable improvements in results and reductions in costs that are really behind a lot of the accountable care payment and financing reform models. I mentioned better risk adjustment for mental health conditions. That will make payers and organizations pay a lot more attention to these kinds of the kinds of patients that you all can have the most impact on. Medicaid rules around ACOs, I think, at least my experience in working with a number of states, is not completely clear. Are they like traditional fee-for-service Medicaid plans where they're typically not covered? Or are they like Medicaid managed care plans, which are more population-based, where there are some more significant requirements? That hasn't been worked out yet, and that's a regulatory issue, I think, for CMS. And also, for those of you who are in private practice, I talk about some of these models that move away from a pure fee-for-service approach to having some patient-level payments. Again, it doesn't need to be a big thing. It doesn't. Some primary care doctors are using versions of this in so-called concierge payments, but I think the next generation of those payments are going to be for helping you meet needs that you have that just don't fit into a once-a-week visit or something like that, but that also aren't too radical of a switch from the way that financing is set up now. So maybe a patient fee that enables you to provide some better after-hour support, better coordination of care with non-mental health service providers, something that's a step in that direction could be a model for implementing these reforms more broadly. And obviously the most important thing, where you all are starting to develop a lot of evidence already, is on the system-wide impact of better access to mental health services. Things that, programs that you're implementing, and especially the policies that can support those programs that lead to measurable improvements in outcomes for patients and measurable reductions in costs. So it is a very challenging environment, particularly for psychologists and other mental health services providers. But I think the good news is, and the reason I'd be optimistic about this, is there's so much unmet medical need and so much opportunity for improving health outcomes while lowering costs as a result of getting mental health services more effectively integrated into the delivery of care, and as a result of moving away from the traditional way that we paid for mental health services on a very limited basis and tying it more to outcomes that really matter to patients. I hope we can get there soon. It will be a marathon, but I am very hopeful because of the leadership that you all are providing in getting us from here to there. Thank you very much for the opportunity to join you today. Thank you.